I would now like to invite our next speaker for the day, Dr. Suneel Mundkur. Dr. Mundkur is a professor pediatrics at the Kasturba Hospital, Manipal. Welcome, Dr. Mundkur.
Good evening to all of you. I take this opportunity to thank Kaho and Ruby Hall Clinic for giving me an opportunity to share a few of my thoughts on rational prescriptions on this auspicious CQE for the medication safety workshop. And being an active clinician, of course, I have really experienced some of the challenges of the prescriptions, and to bring such changes in the prescriptions in my hospital. I bring greetings from Manipal Academy of Higher Education. I am working as a professor of pediatrics in Kasturba Medical College, Manipal, and also an advisor for quality implementation of Kasturba Hospital. If you see, the major killers at present for the patients are the hospital-acquired infections, multi-drug resistant organisms, sentinel events, and medication errors, which we all in the healthcare sector have contributed. And most of them are preventive. Most of them are preventive. Of course, on a lighter note, the only cause of death in India at present is the doctor's negligence. So I will not get into these aspects. So my topic is on the prescription. I take this opportunity to thank Dr. Vishal Bansal for taking care of the first aspect of medication management, that is procuring and storing in the pharmacy, whatever that happens, the process that happens in pharmacy. I have been asked to describe the prescribing challenges. So we can go wrong as doctors, pharmacists, or nurses. So I'll be concentrating mainly on as a clinician, where a clinician or a doctor can have challenges as far as the prescription is concerned. What is rational drug therapy? When we say rational drug therapy, the word definition rational is based on or in accordance with reason or logic. It's the right drug for the right patient in the right dose at the right time by the right route, which is economical. WHO defines it as patient receiving medication appropriate to their clinical needs in appropriate doses for an adequate period of time and at the lowest cost to them and to the community. That's the word definition of the WHO definition of rational drug usage. In a nutshell, the safe, effective, appropriate, and economic use of drugs. So errors can happen anywhere from procurement to monitoring, as you know, and prescribing is one of the challenges to the doctors. So let's try to understand what are the requirements of the prescriptions. There are 3 guidelines for us. The ISMP guidelines, Drugs and Cosmetic Act, and earlier it was called MCI, now it's called NMC guidelines or Code of Medical Ethics. Those who don't know what is ISMP, it's a non-profit organization that works to improve medication use processes and releases guidance and its rationale every 2 years. The latest guidelines is in February 2022. And recommendations may cover any step of the medication, from procurement to administration to storage to management to monitoring to administration and prescriptions, and may cover any healthcare professional involved in the process, maybe a prescriber, maybe a pharmacist, maybe a clinician, or a nurse. The Drugs and Cosmetics Act in India tells that the prescription should be in writing and be signed by the person giving with his usual signature and be dated by him. So very, very clear and very simple words. Be in writing and be signed by the person giving him his usual signature. Specify the name and address of the person for whom the treatment is given, and indicate the total amount of the medicine to be supplied and the dose to be taken. This is what Drugs and Cosmetic Act says. And if you see the Code of Medical Ethics, 1.4.1 says every physician shall display the registration number accorded to him by the State Medical Council and Medical Council of India in his clinic and in all his prescriptions, certificates, money receipts given to his patients. So these are some of the guidelines. And in fact, if you see the NMC in the Code of Medical Ethics very clearly states what should be the prescription. It should be having date and time of prescription, name, address, and age of the patient, the superscription or that RX what we write, inscription, that is medication that has to be prescribed, subscription, that is direction to the pharmacist or direction to the patient, name, address, and signature of the physician, name, route, frequency, time, dose of medications, dose combinations, if at all. There should be clear-cut instructions, and name and signature of the dispensing pharmacist. Please note that all these 10 points are mandatory. It cannot be in less than A5 size paper. A4 size paper or A5 size paper, that's the least you can use for a prescription as per the national NMC guidelines. There are some other guidelines, like say it should be in capital letters. Those who have accreditations, it is mandated. But if you see the National Medical NMC guidelines, it says that all handwritten prescriptions should be preferably in capital letters. Only standard abbreviations to be used. We will talk about it later. No error-prone abbreviations. Avoid TAD, BAD, HS, and SOS orders, and medication orders should be in a uniform location. If the hospital has a drug contact system, or if there is a prescription format, the same format has to be used, because in the court of law, if you use any other format, if you're working in that hospital, that will not be considered as legally valid. CST, continue same treatment, continue all, and continue 1, 2, 4, etc. is legally not valid. So please refrain from prescribing in such methodologies. Prescription should be by the doctors only or a qualified medical practitioner. There are different state laws which give, where even non-allopathy doctors are allowed to write prescriptions in some of the states. So kindly be aware of your state health requirements. Prescription has to be defined or should be documented in the specified format as prescribed by the hospital, and all the data have to be entered in the prescription form completely and legibly, including signatures. So I like that word legibly, because let's see where as clinicians can we go wrong in prescriptions. Why errors in prescriptions or documentations? There is inadequate knowledge. You may not know, or you may not be aware of what are the indications and contraindications. There may be some patient factors such as allergies, pregnancy, comorbidities, and other medications. Wrong patient dose, time, drug, route, inadequate communication, either written or verbal, or when you advise the patient. Documentation may be illegible, incomplete, or ambiguous. Mathematical error when calculating the dosage, and incorrect data entry when using computerized prescribing formats. Duplications, omissions, wrong numbers. So even computerized prescriptions are not error-free. Legibility, yes. This after almost looking at this prescription after 2 years, I came to know that I was reading it upside down. So if such prescriptions are given, I don't know how the pharmacist and the patients will understand what is written and how it has to be taken. I did not know that there was a medical alphabet separately for the doctors and physicians to refer to. And this is what has happened to our handwriting over a period of years, from class 12 to when we get into practice. So legibility is a big question. What should be documented has to be documented. We have already seen these are the things which needs to be documented, and it's better to have a format which satisfies all these documentation requirements. A few words about verbal orders. Why you have to standardize verbal order, telephonic order? We have given so many times in an urgent or emergent situations, we give verbal orders and we expect the nurses to follow it. That is inherently problematic because of different accents and limited short-term memory. You may miss or you may overdo things. So it is better to have a policy to avoid and minimize verbal orders for medications in unavoidable circumstances, like the verbal orders where there is an urgent situation or an emergent situation. Communicate to the nurses through phone and document it in the medical documentation as soon as possible. Resident doctors can be authorized to write the telephone orders to consultants, and documentation counter signature of the verbal order within 24 hours is a must. And always follow the read back policy, not a repeat back. Spell out 1, 5 for 15, for example. Otherwise, 15 may be confused with 50. And chemotherapeutic agents, high-risk medications, high-alert medications, concentrated electrolytes, narcotics, do not allow them to be given by verbal orders. A few words about error-prone abbreviations. And this is the era of abbreviations and thumb generation. And it's very, very difficult sometimes to understand these error-prone abbreviations. For example, milligram versus micrograms, international units versus IV, subcutaneous versus sublingual. The L may get misinterpreted as 1. So there is ISFP's list of error-prone abbreviations, symbols, and dose designations. You can refer to this easily in the downloadable format in the ISMP. A few examples I'll give. Microgram may be mistaken as milligrams, which can result in 1,000-fold dosing over dosage. IU, international units, can be mistaken as IV or 10 sometimes. OD can be mistaken as right eye. QOD or QD may be mistaken as QID, once daily to be given as 4 times daily. And U or small u may be mistaken as for the number 0 or 4 and can cause 10-fold over dosage or greater. So there are suggestions also how to make it less error prone in the ASLP guidelines. So you can follow these guidelines when you write the prescriptions. Some of the examples of drugs where you write the abbreviations like AZT, zidovudine can be mistaken as azathioprine or astrianon, or nitrodrip may be confused. Nitroglycerin infusion may be mistaken for sodium nitroprusside. So using abbreviations may save minutes. Prohibiting abbreviations may save lives. A few words about medication reconciliation. Medication reconciliation is the process of creating the most accurate list possible of all medications a patient is taking, including drug name, dosage, frequency, and route, and comparing that list against the physician's admission, transfer, and or discharge orders, with the goal of providing correct medications to the patient at all transition points within the hospital. So let's not be party to the medication errors. Ensure the list of medication which a patient is taking up to date in relation to post-clinical, past clinical conditions and present care plan. Reconciliation at the transition points should happen, like say admission, transfer from one ward to setting to another, like from ward to ICU or ICU to ward, or discharge. Always ask whether the patient, what medication patient is on, and whether patient requires these medications, whether it's in the appropriate dosage, formulation, and frequency. There should be a system for effective communication during handover regarding reconciliation of medications. The food-drug interactions and drug-drug interactions are another challenges. There are incidents of major drug interaction to the extent of 0.0 to 23.3%. 6 to 30% of all adverse drug reactions or adverse drug events are because of food drug and drug interactions. So let's be aware of this. 2.8% of hospitalizations are because of this, and many of them have resulted in death and serious morbidities, including stroke and intracranial hemorrhage. So e-prescriptions may be of use in situations where there is a pop-off message or an alert which gives you that there is a drug-drug interaction on this patient. But only thing is, when you are prescribing it, all the drugs should be entered. Let's say if you are entering only 1 or 2 drugs on the patient, which patient is having, you may not get the alerts. So be careful when you are using the e-prescriptions. It may be a pseudo assurance that there is a pop-off message if there is a drug and drug. This was what was published in American Journal of Health System Pharmacy in 2007, that results of the study suggest that potential drug-drug interactions continue to be problematic even within a healthcare system with computerized prescriber order entry and computerized alerts for interactions. So e-prescriptions are also not error-free. There are other problems associated with the prescriptions like drug combinations. When you have multiple drug combinations, Be careful about the drug-drug interactions. And not only that, some of the drugs formulations may have the drugs which are in use, so you may have therapeutic duplications. Like, for example, if you want to give paracetamol with ibuprofen and one diclofenac with paracetamol may be double, there may be duplications. Irrational usage, when it is not indicated using the drug. For example, a combination of antihistamine with paracetamol, and there is no fever, there is no need to give paracetamol in such situations. Unapproved combinations, a lot of drugs will have come out with the unapproved combinations. I have seen antibiotic with bronchodilator, with mucokinetic and cough suppressant in one formulation, which is locally prepared. So do not indulge in prescribing such unapproved combinations. For example, tazobactam and sulbactam is combined with almost all the antibiotics, which has no relevance. Avoid writing TID, BID, and SOS and HS orders, which may cause problems and which may not be understandable by the patient. And when you are having polypharmacy, when you are using many drugs, for example, that the patient is on 3 or 4 anti-epileptic drugs, be careful when you prescribe such prescriptions. So it's better to prevent and prepare rather than repent and repair later. Be careful of the patient situations, especially the patients who are on multiple medications, especially patients with another condition, that's renal impairment and pregnancy. Be careful about the effect of renal impairment on the drug metabolism or the vice versa. Patients who cannot communicate well, patients who have more than one doctor, that is multiple team members, team of doctors handling the patient, patients who do not take an active role in their own medication usage, and children and babies where the dose calculation is as per the body surface area or the weight of the patient. These are some of the error-prone situations from the patient side. Be careful about the error-prone situations like inexperience, rushing or reluctant to use aids, doing 2 things at once, interruptions while writing the prescriptions, fatigue, boredom, being in autopilot mode leading to failure to check and double check, lack of checking and double checking habits, and poor teamwork and communication. These are some of the error-prone situations where medical errors can happen, prescription errors can happen. Be careful about workplace related problems like absence of a safety culture in the workplace. Example, poor reporting systems and failure to learn from past, failure to learn from others' mistakes, absence of corrective preventive actions in case of deviations and deficiencies, near misses and adverse events. Absence of memory aids for staff and inadequate staff numbers may result in error-prone aggression. So in a nutshell, how to be having safe prescription practices. Tailor prescribing for each patient. Do not have a unified format for all so that checking is avoided. Learn and practice through medication history taking. Know the high-risk medications and take precautions. I've already, Dr. Bansal has already discussed about high-risk medications, how you're going to check, be careful about it. Know the medications you prescribe well. Otherwise, your patients will teach you. Use memory aids. Communicate clearly what you need to communicate, especially for example, there was one drug called naldixic acid. The dose was 55 milligram per kg in children. And if you do not use the appropriate dose, patient will develop pseudotumor cerebri and may come out with convulsions. Or if you are using rifampicin, you have to inform the patient that all the secretions may be in orange color. So these are some of the things which you have to communicate clearly to the patients. Develop checking habits always and encourage patients to be actively involved. Use generic names. Now the national government has clearly mentioned that you have to write the prescriptions in generic names or pharmacological names. In addition, you can use trade names that they have not mentioned. Report and learn from errors. It is very good to learn from your own errors, but fantastic to learn from others' errors. Include name, dose, route, frequency, and duration of every drug. Inquire about recently ceased medications and ask about over-the-counter medications, dietary supplements, and alternative medications, which may have drug interactions with the current medications. Make sure what patient actually takes matches your list. Be particularly careful across transition of care and be clear what is required and what is not required. Practice medication reconciliation at admission to and discharge from hospital and also in transit points, that is between two settings. Look up any medications you are unfamiliar with, read about it, verify, cross-check, and refer. Consider food-drug interactions, drug-drug interactions, medication that can be seized, and medication that may be causing side effects. Be careful such drugs and also communicate properly to the patients so that they'll also take part in preventing the medication errors. Always include allergy history when prescribing a new medication. Provide patients with the following information: the name and purpose and action of the medication, dose, route, and administration schedule, special instructions, directions, and precautions, common side effects and interactions, and how the medication will be monitored. So it is better to involve the patients also in the medication management thoroughly with proper communication so that they also will be alerted about any of these prescription or administration errors. Thank you for being patient. Thank you for your patient hearing. And I think question and answer will be at the end.